I'm happy to invite everybody. Today's sport medicine going to present a presentation by Associate Professor Dr. Mohamad Shariff in regards accelerating muscle healing. Associate Professor Dr. Mohamad Sharif Abdul Hamid is a sport physician and senior lecturer with Faculty of Medicine in Sport Medicine Unit. He's also a visiting physician at National Sports Medicine Center Bukit Jalil. He is a member of the Malaysia Association of Sport Medicine. His research interests includes sports injury and injury prevention and management. So without further ado, I would like to invite Prof. Sharif to talk about accelerating muscle healing. Prof. Sharif.
Thank you very much, Prof. Nahar, for the introduction. Ladies and gentlemen, very good morning and Assalamualaikum warahmatullahi wabarakatuh. Start by sharing my slide. Oops. Can you see that? Is it visible? Prof. Nahar, can you see that?
Yes.
All right. Okay. All right. Are you seeing the presenter's view or the?
Okay.
Both.
You're seeing both, is it? All right. All right. Sorry. So let me just get this straight first. Not sure how to do this. So I'm just gonna start by sharing you this. It works just now. So okay. So anyway, I'll be talking on or presenting on the accelerating muscle healing, and just a brief overview of my presentation this morning. Just gonna share with you a couple of cases of muscle injury among our national athletes, and also on the current management of muscle injury, as well as the potential roles of autobiological agents in acceleration of muscle healing. The first case is Mr. KS, is 40 years old, our national hockey goalkeeper. He presented with sudden onset of anterior thigh pain, occurs while he was running for the ball. And he came to our clinic about 2 days later and presented with an antalgic gait. And there was tenderness on the proximal one-third of the anterior thigh. And also there's limited range of motion in terms of the active knee flexions, only for about 45 degrees. And also when we tested the isometric knee extension test, it was also quite painful, and subsequently we arranged for an ultrasound which demonstrated a hypoechoic, nearly more than 2/3 of the thickness of the rectus femoris muscle, and this is also visible in the MRI of his right thigh. Rectus femoris changes also there. And the second case is Mr. KHJ, is a 19 years old, our national sprinter. He presented following a sudden onset of stabbing or sharp pain on the posterior thigh. Occurred while he was participating in the final 100-meter sprint event in Singapore. Again, he presented with a similar presentation as the case number one. Tender on palpation on posterior thigh with active knee extension limitation, grossly limited, and as well as pain on resisted knee flexion. And in addition, this is he had the initial injury of the hamstring in 2017 April, and he recovered in May same year, and he re-injured in August 2017. And there's also another two occasion whereby he sustained repeated injury. This is just to highlight that one of the risk factors of sustaining muscle injury or hamstring injury is actually previous history of similar injury. This shows that with the subsequent recurrent injury, the recovery rate tends to be a little bit more longer. Okay, so in terms of the epidemiology of muscle injury, it's based on a few studies that I managed to get. The first one is Shariff et al. In 2019. This is a study, a cross-sectional study looking at all the injuries occurring during the higher education games, Sukan IPT in 2018. And the incident of muscle injury is 23.2%. When we did our study during the Asian Games in Busan, the incidence was slightly higher than that, about 35%. And Lee et al. In a study involved professional footballers, incidence is even higher, about 38.5. This pattern does suggest that as the level of intensity or the level of competition increases, seems to suggest that incidence of muscle injury also increases. Okay. And in terms of the location of the muscle injury, again, based on Lee et al. In 2018, the adductors hamstring was the commonly diagnosed. Similar in the Busan Games, also we tend to see high amount of hamstring and adductor muscle injury. And we look at the grading of injury, grade 2 muscle injuries seems to be frequently diagnosed among our national athletes. And there are several ways in terms of grading of muscle injuries. The common one that we use are based on a clinical evaluation. And in many instances, we evaluate in terms of the pain on palpation, loss of strength, as well as the minimal range of motion assessment. And the grading do reflect on the extent of injury. And similarly, there are also radiological grading system, be it using MRI or ultrasound more commonly. And again, the extent of injury will relate back to the severity of the injury. Grade 1 being less, muscle are involved. Grade 3 means more, and in some cases, full rupture or full tear of the muscle itself. And in terms of the management of muscle injury at the moment, we use a combination of pharmacological, non-pharmacological. There's also a potential role of surgery, especially when the injury is a complete rupture with edges of both stump actually retracted. So those cases, we may require our colleagues from the surgical team to help us out. In terms of pharmacological approaches, the use of NSAID also is controversial. People are still using that, and in some cases, they also combine with corticosteroid. We tend not to do that at the National Sports Institute, Malaysia. In terms of non-pharmacological treatment, various rehabilitation programs have been described, including the progressive agility trunk stabilization, including the ASCLING or eccentric rehab program, as well as more recently, the ASPETA team described 6 stages of muscle rehab program. Just hang on. Sorry, my battery runs low. And electrotherapeutic modalities for muscle injuries is still controversial. And with regard to recovery, despite all the management approach been used, return to sports is quite lengthy, and it ranges between 6 weeks to never, especially for those with a severe grade of injury. At the National Sports Institute, patient or athlete diagnosed with grade 1 take about 2 months to recover, while those in a grade 2 and 3 slightly longer, about 71 days on average. And all this can translate back to the cost in terms of the treatment cost, as well as time away from sports. And it has been estimated about 1.6 billion Aussie dollars per year spent in treating or in managing muscle injury. And also, once athletes go back into the games, usually they take some time to regain their confidence and whatnot before they can achieve the pre-injury level of play. Several factors affect soft tissue healing, of course, including injury factors, individual factors, local factors, as well as the treatment. Can you hear me? All right. As well as treatment. Okay. The question is, Prof. Nahar, can you hear me?
Can hear, but somehow a bit softer.
Oh, all right. Sorry, sorry. All right. Next question is that can we heal? Can we accelerate muscle healing? Can you hear me now?
It's better. It's
Better.
better now.
Thanks. Okay, thanks. Can we accelerate muscle healing? Of course, for to answer that, we need to go back to our basic sciences where we learn in the undergrad. Uh, you call this following injury. Of course, you get inflammation, and then you got all your chemoattractants or inflammatory cells are being called into the injured area, and following that, you get proliferations of new muscle to bridge the gap, and as well as the formation of scar tissue, and the remodeling process can take up to months, even years, depending on the severity of the injury. And all right. And one of the ability of the muscles is actually they have the limited ability of regeneration of new muscle via the activation of satellite stem cells. These satellite stem cells are located in the basal lamina of each myofibers, and in many cases they are very dormant. However, they get activated, especially when there's injury or there's exposed to certain growth factors which activate them. And once activated, these satellite stem cells or satellite cells have the ability to self-renewal as well as to proliferate and differentiate in forming new muscle cells as well as myotubes and so on as muscle fibers. And some of the growth factors which has been shown to be able to affect myogenic satellite cell activities are listed up there. Now, these are all based on in vivo study where they studied individual growth factors, and it's been shown that certain growth factors like hepatocyte growth factors, fibroblast growth factors, insulin-like growth factor 1 and 2, mechano growth factors, as well as the transforming growth factor beta have the ability to affect activation, proliferation, and differentiations of the satellite stem cells or satellite muscle. And these growth factors are also present in the alpha granules of the platelet. The alpha granules are those in the dark color there. And once activated, the platelets releases these alpha granules and may demonstrate the same effect as what I mentioned earlier. In fact, during muscle injury, initial phase, you got torn muscle fibers and torn basal lamina, the formation of a temporary contracted band to seal the torn ends. This is followed by releases all the growth factors. Oh, okay. Uh, all the growth factors and newly formed satellite cells, proliferations and differentiation to myofibroblasts. And at the same time, fibroblasts also produces collagen and scar tissue. Okay, and the newly formed myoblast fuses with myotubes, and these myotubes also fuses with the surviving part of the torn fibers. In the fully regenerated fibers, scar tissue are being organized. And the goal is actually to maximize tissue regeneration or muscle regeneration while minimizing the formation of scar. Just hang on. I'm just going to stop sharing for a while. Sorry. All right. Share my screen again. Screen. So, sorry, I've got issue with my slides.
Kenapa suara tak ada?
Hello. Ada. Okay.
Okay, Prof, can hear you.
Okay. Sorry about that. I'm having issue with my screen actually. I can't share with you. All right. I need to log. Hang on. It's stuck actually. Okay, let me just share. This one. Just- Okay, sorry about that. We try to maximize tissue regeneration by increasing stem cell or use of stem cell factor or growth factor therapy. The only thing is that you have to remind yourself that athletes is a unique population. They have to abide to certain rules, and one of the rules is actually listed in the World Anti-Doping Agency prohibited list. And one of the prohibited method is under M3 is that they are not allowed to use normal or genetically modified cells.
Sorry, your slides are not coming up.
Oh, not come out. Okay, sorry. Display setting. So, can you see it now? Hello.
Can
Yeah, can
Okay.
Prof?
Okay, good. Thanks. So, so it means that the use of normal or genetically modified cells is prohibited. Hence, you need to be careful in terms of using stem cell therapy for athletes. Secondly, use of peptide growth hormones, growth factors, isolated, also falls under the S2 regulation, whereby athletes are not allowed to use it at all time, and hence you need to be careful in terms of using growth factors therapy. The use of platelet-rich plasma or platelet-derived preparation, however, is not under any prohibition and still can be used for athletes. And in terms of platelet-rich plasma treatment or therapy, usually we extract blood from the athletes and anticoagulate and centrifuge it, and based on the different density, they separate it into several layers. And the one which is on the Buffy coat layers is the one that we try to harvest and use it in the clinical setting. And the question being that does PRP work is also needs to be discussed in terms of if you Google up PRP, then you start to see a lot of testimonial on the aesthetic purposes of PRP use. However, there also in a recent review article by Everts, he also mentioned that there is a signified effectiveness of PRP use in other medical fields, including dermatology, cardiac surgery, plastic, orthopedic, pain management, spinal disorder, as well as sport medicine. It has to be stated here, although the principle of PRP preparation is similar, in the market there are a wide variety of PRP kits available, and these kits cost between 500 to 2,500 depending on the type and the brand that you uses. And to a certain extent, they differ not only in pricing but also in terms of the components of PRP, or the contents of the PRP in relation to the platelet level, the red blood cell level, and the total white blood cell level also differ between different kits. We came up with our own technique of PRP. Producing PRP, and the one that we use, or we are using only all the consumables that we have, apart from the centrifuge machine there, and we estimated our cost to be around 120 ringgit per PRP treatment. Okay, and for muscle injury, does it work? Well, you can have a look at this. Is a bit busy slides, just showing all the randomized controlled trials performed by several authors, and what they found that there's 50% show significant recovery following PRP intervention, while the other 50% does not. So if you look closer, though, you can see that they differ in terms of the injury treatment that they provide. So some article use or include only grade 2, while others grade 1 and 2, and also different in terms of the intervention as well as the injection technique that they use. Some are using ultrasound guided, while others are using landmark guided or blind technique. Okay, and this is our study in 2014. We managed to see that there is significantly faster by about 2 weeks recovery in patients treated with PRP in our setting. But to sum up, I suppose current studies still controversial with regard to ability of PRP in accelerating muscle healing. We need to have more robust study, and researchers also advised to be more standardized in describing the technique and the PRP that they use, so that the other can replicate their findings. PRP treatment protocol, we suggest that you need to class the PRP treatment that you use, and which type of muscle you use, how much being used, and how frequent, and whether or not specific type of rehabilitation program are also included in those study. In conclusion, PRP, although it's theoretically promising treatment, the current evidence is still insufficient to recommend for or against the use of PRP. Hence, we need more robust studies before we can decide. And this is just to inform that at the moment we managed to secure grants from the National Sports Institute, and we are conducting this double-blind randomized placebo-controlled trial to evaluate the clinical effects of platelet-rich plasma for grade 2 hamstring injury among our high-performance athlete. At the moment, we have recruited about 20. Our recruitment process has been a bit delayed due to the COVID-19 pandemic, but I think we need extra time actually. So these are some of the references that I use in the preparation of this presentation. And I apologize for the technical issue just now. Thank you very much for your attention, and thanks, Prof. Nahar.
Oh, okay, thank you very much, Prof. Shariff. There are 3 questions at the moment. First, Dr. Masbi has one question in regards. When do you need to order an ultrasound or MRI for muscle injury?
We usually rely based on clinical evaluation, and in our clinic setting at the National Sport Institute, each room have got their own ultrasound, and usually we perform it ourselves, and the need for MRI is becoming less actually at the National Sport Medicine Center. Only when you suspect that there is a nearly full or complete tear, or if you're uncertain when you're performing the ultrasound whether it's a complete or not, then we request for MRI.
Okay. Number 2, there's a question from Prof. YK Chan. Has allergic reactions been described in the peri-administration period
Ah.
of the PRP?
Oh, thank you for the question. Yeah, so far with our experience, the most severe adverse effect that we had with our patient is with our athletes is actually a pain during the procedure itself. We haven't got any uh, severe reaction documented yet, and in many cases we are using the athlete's own blood, so we don't tend to see any local or systemic reaction so far. So I suppose it's very safe. Although there is documented that if you're not using a sterile administration technique, there's a possibility of infection. But at the National Sport Institute, we're using all under aseptic technique with all the necessary clean, sterile procedure abide.
Okay. Now, next, the third question coming from Prof. Sarah. Salam, Prof. Shariff. What about home athletes? A much bigger numbers. How do we prevent in treat injuries without the constraint of regulation for professional athletes?
Okay. Okay. If I stand correctly, it's for uh, patient who's recreational athlete who does not have any uh, constraint with regard to anti-doping or regulation and whatnot. I suppose if they're not competing, then the use of stem cell therapy, the rules regarding use of stem cell therapy as individual growth factor therapy is not they don't have to obey that. So I suppose you can use, but it's just that you need to be careful when you're using growth factors therapy, especially because if you use it for prolonged period of time, we're not really sure in terms of the adverse reaction with the constant exposure of growth factor therapy. In fact, there's a possibility that maybe you get overproduction maybe. So I'm not that experienced using individual growth therapy.
Okay, thank you, Prof. Sharif. Okay. Um, okay, last question. Are there any role of PRP for OA?
Oh, okay. Thank you for the question. For OA, we are actually looking at conducting a systematic review on knee OA and role of PRP. It's still, I know that some of the article that we found on the during our review documented there's a positive. However, some do not see those benefits. So I suppose we're still in the middle there, and we're still fairly unsure in terms of the effect of osteoarthritis and PRP on osteoarthritis. I'm sorry, I can't answer you that. We still have not got any concrete evidence to really support or refute the use of PRP.
Okay. I think that's all for now. Sorry, that was the last question. I think it's about time. So that's all for now from us. Thank you very much, Prof. Sharif, for your talk to give some view and information to others in regards um, um, the current technology on accelerating healing process. Again, thank you, Prof. Sharif, and thank you everybody for joining us for today's session.
Thank you.